Welcome back. This week, we'll take a short detour. But it's not a detour, it's something related to the conversations on healthcare research in India that we have been having over the past few weeks. But we'll start looking at the issue of research questions. And we look at it from different perspectives. We may not cover the entire thing in today's discussion, but we look at it from different perspectives. The research question is arguably the most important part of any research project, of any research study. That's a question for which we are seeking answers. And we then apply those answers that we get onto a population or to an individual, and we see if the question is answered in practice as well. So the research question is where the research study actually begins. Now, as I mentioned in the previous discussions, in the previous talks, in the previous sessions that we've been having, we got a large population in India. We got a large population of people with illness as well. We've got many medical colleges, we've got many healthcare institutions, we've got many healthcare practitioners as well. If the healthcare infrastructure in India, as it exists, with all its limitations and its strengths, as it exists, was answering questions that were relevant to the population healthcare needs of India, it's natural that we would expect that our healthcare statistics will be hopefully on the better side. Yet invariably we find that our healthcare statistics for India, for large segments of India, not all parts of India, but for some segments, definitely large segments of India, the healthcare statistics or the indicators are on the poorer side. Or if we rank them on a global scale, we would be possibly among the top tier global countries, top tier countries that have got poor health indices. For many public health conditions, even if let's say that let's take diabetes, let's take preterm births, let's take pregnancy-induced hypertension, let's take non-communicable diseases, let's take infectious diseases, malaria, tuberculosis, let's take blindness, let's take visual impairment, coronary artery disease, stroke, trauma, road traffic accidents. So for a whole set of conditions, we are there in the top tier. Now, a reason we are there in the top tier is also because of the large population that we have. So in terms of absolute numbers, it's expected, it's natural that we would be placed among the top tier in terms of absolute numbers of a condition. Unfortunately, we are also there among the top tier when we look at it from a relative aspect as well, in terms of the proportion as well. Why does this dichotomy persist? Why, despite advances in healthcare, despite the skill levels of our healthcare professionals, despite multiple training courses, formal, informal, despite so many medical colleges being set up, and despite an healthcare infrastructure that's being built, as well as parts of the healthcare infrastructure that's being neglected. We can't discount that as well. Why does this dichotomy persist? Why do we still rank in the top tier of countries that have poor healthcare indices? Can we blame it all on the lack of healthcare infrastructure? We could talk about budgetary provisions. Budgetary provisions or budgetary allocations for health is very, very low in India, which therefore translates to poor resources, poor healthcare infrastructure. But can we blame it all on a poor healthcare infrastructure? To look at that from a different perspective, leaving aside the economic perspective, leaving aside the budgetary allocation perspective, resource utilization, resource management. We'll discuss those things later. But leaving that aside for the moment, we have 560 plus, maybe around 562 medical colleges in India. When we say 562 medical colleges in India, it translates to 562 learning hubs where doctors are trained to take care of the healthcare needs of this country. It's been a steady increase over the years. Over the past decades, it's increased in leaps and bounds. Now, the question that comes to our mind is, or the question that we need to look at is, has the increase in numbers on the quantity of the medical colleges as a means to improve the healthcare infrastructure and translate into improved healthcare needs of the population, actually translated to better health indices for the population of this country? And we can look at the population of the districts and the surrounding neighborhoods where the medical colleges are situated. And the reason I bring this up is that, well, besides the obvious reason that taxpayer money is going to fund quite some of this, a lot of them are in the private sector as well. But we are having these hubs where we are training people to become doctors. And if the training is good enough, and if the training is community oriented, if the training is oriented towards a goal of improving healthcare outcomes in this country, then it's natural that we question whether this increase in the number of medical colleges has translated into tangible, better health outcomes, and if so, on what indicators? Does that relate to research? Well, it does in a sense, because it does give us the opportunity to bring in understanding the healthcare needs of societies and communities, and not just the individual person who comes to you for care, as part of the medical curriculum. And it's a big question mark if that is happening on a consistent, regular basis across all hospital, medical college, teaching hospital settings. Something that we need to think about. Let's look at the other aspect. We got about 38,000, maybe around 37,000 postgraduate degree seats in the country, and maybe around 1,000 diploma seats in the country. Add to it the diplomate national board seats, and you might have, let's say, close to 40,000 or 45,000, somewhere in that range of postgraduate seats that are available in the country. Every postgraduate degree has a research dissertation, a thesis or a dissertation that is mandated, that has to be submitted. And the thesis or dissertation is supposed to be the output of a research study. So let's look at what that means. That means on an annual basis, we have the potential, we have the possibility for close to 40,000 research questions that can study problems that are relevant to the population of India and come up with solutions. And I say it can come up with solutions because the dissertation is supposed to span a period of 2.5 to 3 years, the duration of the post-graduation course. At least 2 to 2.5 years. So if you plan it properly, it can lead to the development of long-term studies, and it can lead to the development of solutions as well. So on an annual basis, we have the opportunity for 38,000 to 40,000 research questions that can address and find solutions to local population healthcare needs. You don't get your post-graduation degree if you don't submit your thesis. Let's say there are dropouts. Let's say there are people who don't succeed in completing their post-graduation. Let's discount a number, an arbitrary number. I'm not sure of the exact, so an arbitrary number. Let's say that we still have 30,000 theses that are submitted every year to universities in India, in different states. That's 30,000 research questions that can address the healthcare needs of our population. The question which you have to clearly think about is this pool, is this huge possibility being optimally utilized? Every postgraduate student has a guide, might have a co-guide as well. And the guides and co-guides are, at least in theory, well experienced. There are criteria before you can become a guide. There are criteria before you can become a co-guide. Part of the criteria includes your clinical experience, the duration of service that you have had, the practice that you have had after you completed your post-graduation, and your publications and research experience as well. So 30,000 to 38,000, 40,000 research questions are possible in India every year that can look at problems that affect the health of the local population and find solutions to this. Is it fair then to say that we don't have the healthcare infrastructure or the resources to address our local health needs? Are we optimally utilizing the resources that we have? Now, I'm not making an argument that we have enough resources. I'm not saying that the budgetary allocation is sufficient. It's grossly insufficient. We don't have enough resources. We have neglected and possibly broken down many good systems, especially at the primary care level and the secondary care level. We have shifted more to a tertiary care, advanced tertiary care, corporate healthcare system. Part of the reason is that the pool where we can address local population needs, we have this huge pool, 38,000, it's 35,000, 40,000 postgraduate students who have to do a research study every year. And if you're not utilizing them, then one consequence is that if you're not utilizing them to understand and study and find solutions to local population health needs, one consequence that happens is that we are actually breaking down the fluidity, the strength of the links between the primary, secondary, tertiary care levels. The links between the community healthcare and a hospital-based or an institutional-based healthcare system. And we need to see why that's happening. So then you might think, okay, well, if let's say 30,000 to 35,000 questions are possible Why is that not happening? Now, can that be related? In this particular talk, I'll try to link that with the type of questions that we are building up. Can that be related to the type of questions that we take? Are the questions that we seek answers for confining ourselves and our studies and our research almost entirely to the population that is present within the hospital setting or that comes to us seeking care? Unless, of course, you are in a postgraduate sector that necessitates you to go out in the community, like community medicine, family medicine. So we need to look carefully at the selection of questions. One thing to consider there is that clinical questions will come from clinical observations and will come from clinical patients. That's fair enough. But if the observations are limited only to the clinical symptomatology and to a clinical science within that person or in that person, and do not consider the entirety, then the questions will not expand or go into factors, external factors that can affect the person. The environmental factors, societal factors, social factors, developmental factors. Is that part of healthcare? Well, if you give a treatment, if you prescribe a treatment, hopefully you would be inclined to know and understand if the person will get better with that treatment, and the person can get better with that treatment if the person follows the instructions and takes that particular treatment schedule appropriate. Can they afford it? Is it available where they're going back? Is it accessible? Will they come back for follow-up? Is there a mechanism for us to know what's happening with them, with the treatment? These factors do matter when we try to improve the healthcare. Otherwise, we are just a prescription pushing field, which is not the purpose of medicine. The purpose of medicine is not to prescribe a medication, prescribe a therapeutic regime, or to do a surgical intervention. It has to go beyond that to ensuring that these processes lead to better health, or at least sustained health or maintenance of health and well-being in that particular person. So we need to look at where the questions come from. Do the questions come from the needs of the local health, or the healthcare needs of the local population? Let's look at these questions. Let's look at the questions as they develop more frequently. Now, the thing to remember here is that is the question that you pick based on a healthcare need of an individual. Is a question that you pick based on healthcare need of a local population or a community. Is it based on a global need? When I say global need, is it that everyone around the world is doing that, and so it makes sense for us also to do that? Is it based on a career or a future career perspective that I would like to move further into this particular area, and even though it may not be directly relevant to the healthcare needs of my local population, it gives me expertise and the ability to go deeply into something which I can then use to help other people in other populations elsewhere. That's fair enough. There's nothing wrong with that. So you can see that the questions can come from different angles. Add to that now the issue of publications, publishing in journals, publishing your thesis in journals, publishing papers in journals, presenting your papers in conferences, getting awards, the competition around it. And so the question naturally takes a step back. You look at the question and think, well, is this something that can be presented? Is this something that can be published? Is this something that will add value to me if I put it on my CV for my further career prospects, either in the academic or non-academic sector? These are natural considerations that come around the question. Somewhere along the line, fleetingly, I'll be very honest, fleetingly, there might be the consideration about doing a particular study for the sake of learning something, just for the sake of learning something related to that. So we can call it science for the sake of science. You're not really looking at the external things, but within a dissertation setup where you have to submit something, that becomes a limitation. And it becomes a limitation because we need to look at what we evaluate in the dissertations and the thesis that are submitted. Are we evaluating the process that is being used? Are we evaluating the ability of the student to apply these processes that are learned later in their career, in the clinical practice? Or are we just evaluating the outcomes as they are written in the dissertation? What exactly is being evaluated as part of the dissertation? Are we evaluating the application? Are we really looking to see if of all these theses and all these dissertations that are submitted, how many of them can create, have translated or have been applied to create an impact on the healthcare needs of the local population? Now, conceptually, you have to realize, conceptually, the dissertation has got a process that starts from the submission of the thesis synopsis. Within the first few months of your joining the post-graduation course, which is quite strange in itself, because as soon as you join the post-graduation course, in the first 3 months, you're submitting a synopsis on something that you think is important. Does that give you enough time to pick out a question that has importance for you as an individual, for the person, an individual as a patient, for a society or a community, and for the healthcare institute that is housing all of you, that whole environment? So does the question, does the process of dissertation matter? And what happens when we leave aside the healthcare needs of the local population and look to pick questions that are of global importance? An important thing to remember here is that global populations that are looking a lot at molecular genetics, genomics, that are looking at advanced techniques, a lot of them have got a grip on the basic healthcare needs of the population. And they're moving into the advanced areas because they have got a grip on the basic foundational needs of the population. I won't say that it's all perfect, but they've got a certain amount of grip on it. They managed to reduce a lot of those basic healthcare needs, met a lot of those basic healthcare needs, that they're now able to elevate their questions to the next advanced level. Is it fair for us then to just pick up those questions, pick up those advanced levels, while the vast majority of people here, the vast majority of our population, the vast majority of our healthcare infrastructure as well, is still struggling with meeting basic healthcare needs. Are our priorities imbalanced? Again, this does not mean that there is no role for those no role for advanced technology. There's no role for advanced diagnostics. No, that's not what I'm saying. What I'm saying is that, are we missing the bus by not looking to leverage those advancements and aligning it with the needs, the local population healthcare needs that we have? Aligning the technological advances, trying to find ways to bring that and leverage that into meeting basic healthcare needs for our population. Some things to think about. We look at how the direction of questions can change the entire direction of healthcare infrastructure development, as well as healthcare infrastructure, meeting healthcare needs of populations as we move along. But for today, I want to leave you with these thoughts. As much as it is evident that we have a low budgetary allocation for healthcare needs, as much as it is evident that we have a poor healthcare infrastructure built in our country, and if the pandemic has not shown you that, if you've not seen it through this pandemic, you seriously need to take a look at yourself. Leaving aside those things, are we fully utilizing the things that we have control? Optimally utilizing the medical college system, that whole network of teaching and training doctors to be. Optimally utilizing the 38,000 odd postgraduate seats, postgraduate degrees and diplomas, students that are coming in every year. Are we leveraging the expertise of the faculty? Are we leveraging the huge population of postgraduate residents and doctors? And taking a step below down, the huge population of house surgeons and junior residents as well. Senior residents, junior residents, house surgeons as well. Actually translate into better healthcare outcomes for local populations. Now, if you say for the whole of India, it becomes a big elephant. But if you say for local population around the area where the medical colleges are situated, it doesn't look like such a, well, it is a huge task, but it doesn't look like such a mammoth, huge task as covering the whole of India in one. This is a thought that I want to leave you. Because as healthcare professionals, this is something that we can control. This is something that we can take control of. This is something that we can use optimally. We can change to improve the healthcare indices of our country. Take care, stay safe, be happy, think along, and see you again next Sunday.